guys, welcome back to my channel. Today we will discuss about one of the endocrinology topic that is important for SCE endocrinology exam as well as for endocrine clinics. So the topic of our discussion today is erectile dysfunction. This is quite a common topic. We see multiple patients in clinic with this complaint. So let's go ahead from we will do reading from the Oxford Handbook of Endocrinology and then we will discuss the extract. So what is the definition? Definition is consistent inability to achieve or maintain an erect penis sufficient for satisfactory sexual intercourse. It affects 10% of males, and more than 50% of these males are of age more than 70 years. So what is the physiology? Physiology of male sexual function. The erectile response is the result of coordinated interaction of nerves, smooth muscles and blood vessels. So out of these smooth muscles, there are muscles called corpora and pelvic muscles. So these muscles along with nerve and blood vessels play the role in erectile response. It is initiated both by psychogenic stimuli from the brain and or physical stimulation of genitalia, which is modulated in limbic system, transmitted down the spinal cord to the sympathetic and parasympathetic outflows of penile tissue. Penile erectile tissue consists of paired corpora cavernosa on the dorsum of penis and corpus spongiosum. So corpora cavernosa is paired while corpus spongiosum is single. They are surrounded by the fibrous tissue known as tunica albuginea. In the flaccid state, the corporal smooth muscle is contracted, minimizing corporeal blood flow and enhancing venous drainage. So, in flaccid state, it is contracted. Blood flow is decreased and venous drainage is increased. Activation of the erectile pathway result in penile smooth muscle relaxation and cavernosal arterial vasodilatation. As the corporeal sinuses fill with blood, the draining venules are compressed against the tunica albuginea, so venous flow is impaired. This results in penile rigidity and an erection. So, during the active process of erection, blood flow is increased, so arterial supply is increased, while the outflow venous drainage is decreased. While we have studied that during the flaccid state, it's opposite. Arterial supply is decreased, while the venous drainage is increased. So next one is corporeal vasodilatation is mediated by parasympathetic neuronal activation. This is important. Which system here? Parasympathetic neuronal activation, which induces nitric oxide release by the cavernous nerves. This activates guanylyl cyclase, thereby increasing cGMP and causing smooth muscle relaxation. The tumescence occurs when the inactivation of cGMP by the enzyme phosphodiesterase, resulting in smooth muscle contraction and vasoconstriction. Ejaculation is mediated by sympathetic. So erection itself, it is parasympathetic, while ejaculation is sympathetic. So important thing here in the pathophysiology is there are three kinds of things involved. There are smooth muscles, pelvic muscle, blood vessels and nerve. Two kinds of stimuli are important. One is psychogenic stimuli and other one is physical stimuli. The erection is parasympathetic response, while ejaculation is sympathetic response. What happens actually? cGMP is activated and it causes smooth muscle relaxation by the corporeal vasodilatation. So again, for the cGMP enzyme involved is phosphodiesterase. So this was the physiology of male sexual function. Now we will go to the pathophysiology. Pathophysiology, erectile dysfunction may thus occur as a result of several mechanisms. Neurological damage. So this is very important to understand what could be the pathology, how the patient can develop. It could be either neurological damage, it could be arterial insufficiency, venous incompetence, androgen deficiency or penile abnormalities. So all the process which is involved, nerve damage will cause, neurological damage can cause it, then arterial insufficiency, then venous incompetence, then androgen deficiency, and finally penile abnormalities. So evaluation of erectile dysfunction, this is very important for the clinics. You will take the history of important history, sexual history, extent of dysfunction, how much it is, from how long it is, and how is the progression. Is it getting worse or is it getting better? presence of nocturnal or morning erections, abrupt onset of erectile dysfunction which is intermittent is often psychogenic in origin. If it is of abrupt onset, most likely it is of psychogenic origin. Then progressive and persistent indicate an organic cause. So two things, abrupt and intermittent is of psychogenic, while persistent and progressive is of organic cause. So you need to look for the underlying cause, what could be the cause. Besides this, you will take history of hypogonadism. You will ask about reduced libido, muscle strength and sense of well-being. Then full medical history, for example, of diabetes, liver cirrhosis, neurological, cardiovascular or endocrine causes. Diabetes, liver cirrhosis, neurological, cardiovascular, endocrine. Intermittent claudication suggests a vascular cause. It will cause arterial insufficiency definitely. A history of genitourinary trauma or surgery is also important. Recent change in bladder or bowel function may indicate a neurological damage. And then is the psychological history, which will rule out the psychogenic cause. Then is the drug history. In the drug history, you will ask about onset of importance in relation to commencing a new medication. That is very, very important. Then is the social history. Sometimes stress can cause it. Relationship history is also important. Okay, next one is smoking history, recreational drugs including alcohol. So again, I will repeat the causes. The history in the history you will ask about the sexual history, hypogonadism history, full medical history, because there can be medical causes, either systemic causes, neurological causes, psychological causes, and trauma or surgery is also important. Then is the drug history. Is there any relation to commencing new drug? Then is the social history like stress or relationship history, smoking history and recreational drugs. So about the examination, what examination you will do in the clinic? You will look for the evidence of primary or secondary hypogonadism, evidence of endocrine disorder in the form of hyperprolactinemia. So hyperprolactinemia can cause erectile dysfunction, thyroid dysfunction can cause that, hypopituitarism, other complication of diabetes if present, like autonomic neuropathy and progressed form of diabetes. Then you will look for the evidence of neurological. So from the endocrine, hyperprolactinemia, increased prolactin, then thyroid dysfunction, then hypopituitarism, then diabetes. These four are major causes. Then look for the evidence of neurological disease, either autonomic or peripheral neuropathy and spinal cord ligaments. Evidence of systemic disease include chronic liver disease, cardiac disease and peripheral vascular disease. So you will examine these things. Then genital examination, assess testicular size, testicular failure and penile abnormalities like Peyronie's disease. And then is the this is the box which is showing again all the same things. Causes of erectile dysfunction, psychological, and consist of 20%. 20% of the patients have erectile dysfunction due to psychological causes. It can be stress, anxiety or any psychiatric illness. Then 25% are related to the drugs. So it's quite a big proportion. 25% is related to the drugs like alcohol, antihypertensive like diuretics, beta blockers, methyl dopa, cimetidine, marijuana, heroin, methadone, tranquilizers, TCAs and all these. And then is the endocrine causes, hypogonadism. So these are the three major. Endocrine are 20%, 20% psychological and 25% is drugs related. Then is next one is the neurological causes. So endocrine, we were going through endocrine. It can be hyperprolactinemia, diabetes, thyroid. These are the endocrine causes. Then the neurological, spinal cord disorder, peripheral autonomic neuropathy, multiple sclerosis. So multiple sclerosis is also one of the cause. Then is the vascular like peripheral vascular disease, diabetes, trauma and venous incompetence. And finally there can be other causes like hemochromatosis, debilitating disease, penile abnormalities which we have already studied, Peyronie's disease and priapism, and finally prostatectomy can cause this as well. So these are the major causes. So among these most common are psychological, endocrine and the third one is drugs. So what investigations you are going to do? Investigations would be baseline investigation and specific investigation. Baseline investigation you will do morning fasting testosterone. Then the liver function test, prolactin, LH and FSH if serum testosterone is low. And then fasting blood glucose, renal function test, then lipid profile, TFTs and ferritin. So important one is you will do LFTs, RFTs, lipid profile, fasting blood glucose, thyroid profile. Then is this morning testosterone level, fasting testosterone level. From the hormone you will do LH, FSH, prolactin and testosterone. And finally you will do serum ferritin as well to rule out hemochromatosis. What are the specific investigation or additional investigation? You will they are rarely required. Sorry. They are rarely required to assess vascular causes of importance if corrective surgery is contemplated. So there could be intracavernosal injection of a vasodilator, for example L-prostadil E1 or piperine. A sustained erection excludes significant vascular insufficiency. So usually they inject vasodilator to see if it is related to vascular insufficiency. If there is sustained erection, then it will rule out the vascular insufficiency. L-prostadil E1 or a piperine you will inject intracavernosal. And then is the penile Doppler ultrasound. Cavernous arterial flow and venous insufficiency is assessed and they are ruled out through the ultrasound. So again I will just go through the investigation quickly because this is very important for the clinic. You will do baseline investigation and additional investigation. Baseline include liver function test, thyroid function test, renal function test, lipid profile, fasting blood glucose. And then you will go to the hormonal profile. Hormones include fasting testosterone morning, serum morning fasting testosterone, prolactin, LH, FSH only if testosterone is low. Once you will get the result of testosterone and you find it is low, then go ahead with the other hormones. And finally, do not forget to check ferritin to rule out hemochromatosis. Then there is additional investigation to rule out the specific cause of erectile dysfunction. It includes intracavernosal injection of vasodilator and secondly Doppler ultrasound of the penis. Penile Doppler to rule out the arterial flow and venous insufficiency. Then is the management of erectile dysfunction. So management is depends upon the underlying cause. Treat the underlying disorder and withdraw offending drug if it is related to the drugs. Androgen, this should be first line therapy in males with hypogonadism. Hyperprolactinemia when present should be treated with dopamine agonist and the underlying cause of hypogonadism are treated. So this is according to the cause. If their testosterone is deficient, then treat with androgen. If there is hyperprolactinemia, give dopamine agonist which will suppress the prolactin. And finally, if it is due to hypogonadism, treat that as well with the gonadotrophins. Then phosphodiesterase inhibitor act by inhibiting. We have studied about the CGMP activity. So what phosphodiesterase inhibitors will do, they will enhance the CGMP activity in erectile tissue by blocking the enzyme PDE5, thereby amplifying the vasodilatory action of nitric oxide and thus the normal erectile response to sexual stimulation. So what we read there, that usually CGMP activity is decreased because of PDE5 inhibitor. So phosphodiesterase inhibitor will inhibit the enzyme and they will increase the CGMP activity. Therefore, vasodilatation will improve and nitric oxide will improve and it will increase the sexual stimulation. So the success rate with these trials is 50 to 80%. Then is the L-prostadil, which is also phosphodiesterase inhibitor. So L-prostadil result in smooth muscle relaxation and vasodilatation. It is administered. We were administering this as a diagnostic test as well, and it is also therapeutic. So it is administered intraurethral and then absorbed into the erectile body. 60 to 66% success rate, and side effect is only because of the injection there will be local pain. Then is the intracavernous injection. It has 70 to 100% success rate, highest in men with non-vasculogenic impotence, in which it is not due to arterial or venous insufficiency. Then L-prostadil is a potent vasodilator. The dose should be titrated in 1 microgram increment until the desired effect is achieved in order to minimize the side effect. So we will titrate the dose every time by 1 microgram to achieve the desired effect. Piperine, a phosphodiesterase inhibitor, induces cavernosal vasodilatation and penile rigidity but causes more side effect. So L-prostadil has less side effect as compared to piperine. There is a side effect priapism in 1 to 5%. Patient must seek urgent medical advice if an erection lasts for more than 4 hours. There is the fibrosis in the injection site in up to 5% of the patient. Minimize risk by alternating sides of penis for injection and injecting a maximum of twice a week. So this piperine and L-prostadil is again both diagnostic and therapeutic. Infection is also a side effect at the injection site. Then contraindication, sickle cell disease is a contraindication. What about the injection technique? Avoid the midline is to avoid the urethral and neurovascular damage. Clean the injection site, hold the penis under slight tension and introduce the needle at 90 degree. Inject after the characteristics give of piercing the fibrous capsule. Apply pressure to the injection site. This is not important for the exam and also for the clinic as well. The other things which can be used in treatment are vacuum devices. Results are good with 90% of the male achieving a satisfactory erection. The flaccid penis is put into the device and air is withdrawn. Creating a vacuum then allows blood to flow into the penis. A construction band is then placed onto the base of the penis so the erection is maintained. This should be removed within 30 minutes. Side effect is again pain and hematoma. So this table is showing phosphodiesterase 5 inhibitor, the initial doses and different kinds of the phosphodiesterase 5 inhibitor, sildenafil, vardenafil and tadalafil. So the dose of sildenafil is 50 to 100 milligram per day, then 20 to 20, 10 to 20 and 10 to 20. Recommended interval between drug administered and sexual activity. So it should be within 60 minutes and 30 to 60 minutes. With tadalafil it is more than 30 minutes. Then is the half-life. Half-life of sildenafil is 3 to 4 and tadalafil is 17 hours. So it has the longest half-life. And then for vardenafil is 4 to 5 hours. Adverse effects include headaches, facial flushing, dyspepsia, nasal congestion and visual disturbance. Then is the PDE5 inhibitor contraindication and cautions. Contraindications include MI and stroke, recent MI and stroke, unstable angina. And then is the current nitrate use including isosorbide, mononitrate and GTN. Then is the hypotension and severe because it causes vasodilation, so it can worsen these things. Severe heart failure, severe hepatic impairment, retinitis pigmentosa and ketoconazole are HIV protease inhibitors. Caution: we need to decrease the dose in these conditions: hypertension, heart disease, Peyronie disease, sickle cell, renal hepatic impairment, leukemia, multiple myeloma and bleeding disorder. Avoid concomitant opiate including dihydrocodone which may prolong the erections. Opiates increase CGMP and nerve ending as well. So the whole mechanism here is to increase the CGMP by anything. Then another one used for the treatment purpose is penile prosthesis, and then psychosexual counseling, particularly for male with psychogenic impotence and in male who fail to improve with the above therapy. And finally is the surgical treatment, rarely indicated as results are generally disappointing. Revascularization technique may be available in specialist centers. Ligation of dorsal veins may restore erectile function temporarily in men with venous insufficiency, although rarely permanently. So this is all about erectile dysfunction. I will go through this again, just a quick overview. Erectile dysfunction is basically happening in more than 10% of the males, and out of these 10%, more than 50% are of age more than 70 years. So physiology, we have studied that the effect of CGMP is decreased. It involves nerves, muscles of penile muscles, smooth muscles of corpora cavernosa, and then the pelvic muscles, and finally the blood vessels. The pathophysiology can involve these mechanisms: neurological damage, arterial insufficiency, venous incompetence, androgen deficiency and penile abnormalities. Evaluation of the erectile dysfunction: initially we need to take history in detail, sexual history, symptoms of hypogonadism, full medical history to rule out the systemic causes as well, and finally the drug history is important, and then is this social history. 5 kinds of history we need to take. Physical examination, we need to look for the primary or secondary causes of secondary hypogonadism signs, then the evidence of endocrine disorder. If it is you think it is due to endocrine, then do the endocrine examination for diabetes, thyroid, hypopituitarism and hyperprolactinemia. Then is the neurological disease, you will look for peripheral neuropathy or autonomic neuropathy and spinal cord lesions in the form of nerve sensory levels, etc. And then the evidence of systemic disease like liver, vascular and cardiac disease. Then is the genital examination, which is very important here. You need to assess the size of testicles, to look for testicular failure, and then look for any penile abnormalities. So again, the causes major 25% is related to the drugs, and 20% is related to psychological, and 20% are related to endocrine, and the rest of the causes are almost 35%, vascular, neurological, and hemochromatosis, etc. Then in the investigation consists of baseline investigation and specific investigation. Baseline investigation consists of liver profile, renal profile, and blood glucose, lipid profile, thyroid profile, ferritin, and serum morning for fasting testosterone. If this testosterone is low, you need to go ahead with the hormonal profile, LH, FSH, and prolactin. Additional investigation consists of injecting an injection of vasodilator to rule out the vascular insufficiency, and then is the penile Doppler ultrasound. Treatment is again treat the underlying cause. If it is related to drug, stop the drug. If it is related to systemic disorder, treat the systemic disorder. Then androgens are first line treatment, and if it is hyperprolactinemia, then give dopamine agonist. And phosphodiesterase inhibitors are important to increase CGMP, which include L-prostadil, sildenafil, vardenafil. So L-prostadil is again causing smooth muscle relaxation and vasodilatation, and there is the intracavernosal injection again of the L-prostadil and papaverine. And also there are vacuum devices, then there are prosthetic devices, and finally there is surgical option as well. But surgical option, we go ahead with the surgical option very rarely. Among the phosphodiesterase inhibitor, half-life is important. Tadalafil has the longest half-life of 17 minutes. Then is the vardenafil, and then is the sildenafil with 3 to 4 hours of half-life. And then is the adverse effect of these phosphodiesterase inhibitor, which is important to let the patient know before prescribing any medication: headaches, flushing, dyspepsia, nasal congestion, and visual disturbance. Very important to understand the contraindication of phosphodiesterase inhibitor: recent MI, stroke, unstable angina, nitrates use, hypertension, heart failure, liver failure, retinitis pigmentosa, and ketoconazole are phosphodiesterase inhibitor. And very important, psychosexual counseling. If you think that the cause is related to psychological, then do the psychosexual counseling for the patient. That's about it about erectile dysfunction. See you again with another topic of endocrinology. Thank you for watching.